Everyone. Earlier we talked about bilirubin metabolism. Today we are going to talk about jaundice and its type and how we are going to evaluate jaundice. We can classify jaundice as prehepatic jaundice, hepatic jaundice, as well as posthepatic jaundice. So prehepatic is in the blood system. So prior till the production of bilirubin, if there is any problem, it is going to be prehepatic. And if the problem is in the liver, either in the conjugation, steps of conjugation, it is going to be hepatic jaundice or anywhere, any kind of liver pathology. And post-hepatic is after conjugation, the bilirubin is not able to get outside of the liver because of the biliary obstruction, and that is post-hepatic jaundice. Okay, we can also classify them based on the biochemistry, either as unconjugated hyperbilirubinemia, which is indirect bilirubin is raised, or it can be conjugated hyperbilirubinemia, or it can be mixed pattern. The bilirubin can be classified as unconjugated bilirubin or conjugated bilirubin based on the Vandenberg reaction. It is a biochemical reaction where the bilirubin is coupled with diazonium salt to form a colored complex. The water-soluble bilirubin, that is the conjugated bilirubin, directly reacts with the agent, whereas unconjugated bilirubin has to be mixed with alcohol first to form the reaction. So it is also known as indirect bilirubin. As we earlier saw, the other form of classification is based on where the pathology is taking place. So it can be prehepatic, hepatic, or posthepatic. So prehepatic is actually taking place in the blood. Hepatic is in the liver, and posthepatic is in the biliary drainage system. We will discuss about each types of jaundice. Okay. So prehepatic jaundice, it is because of hemolysis, and this hemolysis can be due to congenital cause or acquired causes. So hereditary or acquired. What are all the hereditary causes of hemolysis? So there may be membrane defects or enzyme deficiencies or abnormal hemoglobin production. Membrane defects examples are spherocytosis, elliptocytosis, enzyme deficiencies like J6PD deficiency or pyruvate kinase deficiency, and abnormal hemoglobin production like sickle cell anemia, thalassemia, all those things. Acquired causes is mainly immune hemolytic anemia. It can be autoimmune or alloimmune hemolytic anemia. And MAHA, microangiopathic hemolytic anemia. Examples are hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, etc. Paroxysmal nocturnal hemoglobinuria, or it can be drug-induced or other infectious causes which can cause hemolysis, like mycoplasma infection, malaria infection, all those things. So if we see the blood picture, because of the hemolysis, what happens? There is going to be increased production of bilirubin, and this is going to overwhelm the liver capacity. So whatever bilirubin is going to remain, it will remain as unconjugated bilirubin. The remaining hyperbilirubinemia will be reflected as unconjugated hyperbilirubinemia, and urinary urobilinogen will be increased because whatever bilirubin was conjugated, it will reach the intestine, and whatever is reaching, it is going to form as urobilinogen, stercobilinogen. So serum urobilinogen will be raised. Laboratory picture in prehepatic jaundice. Total bilirubin is going to be raised, and the component is mainly indirect bilirubin, and urobilinogen is also raised. And because of hemolysis, there is going to be anemia, elevation of serum LDH, and reduced haptoglobin. These are all markers of hemolysis. In the peripheral blood picture, you will see lies the RBCs. See, this is one of the helmet cells, which is marker of hemolysis. We also call them as cystocytes. Now we will talk about the hepatic causes of jaundice. So there are various liver pathology which will result in hepatic jaundice. Some of the causes are infectious causes. So it can be viral hepatitis, bacterial especially leptospirosis, or parasitic infections. It can be toxins like alcohol and various drugs. It can be iatrogenic too. And neoplasia, it can be primary liver tumor, or it can be metastasis. And autoimmune, like autoimmune hepatitis, and some of the congenital or genetic causes like Wilson's, hemochromatosis, and alpha 1 antitrypsin deficiencies. Here, the blood picture in hepatocellular jaundice is going to be total bilirubin is going to be elevated, and the pattern is going to be mixed. It can be either unconjugated or it can be conjugated. And since the liver is involved, liver enzymes will be elevated. That is transaminases, AST and ALT, both of them will be elevated. And other functions of liver will also be impaired. So especially PT, prolonged and INR will be raised because most of the clotting factors are produced in the liver and serum albumin will be reduced. So now we will talk about the post-hepatic causes of jaundice. So post-hepatic is mainly because of obstruction in the pathway, and this can be because of benign or malignant. Benign causes, mainly we will talk about the benign pathologies, mainly because of stones, okay, cholelithiasis, or it can be post-op strictures. And because of both these things, there can be infections. Ascending cholangitis also can cause obstruction and parasitic infections. Other benign etiology can be because of autoimmune. Some of the autoimmune causes will include primary biliary cirrhosis, primary sclerosing cholangitis, and IgG4 cholangiopathy. Another malignant etiology will include pancreatic CA, cholangiocarcinoma, lymphoma, or metastasis. So these can cause obstruction in the pathway of the biliary transit of bilirubin, and it can cause hyperbilirubinemia. In obstructive jaundice, if we have to see about the biochemistry, it is mainly direct bilirubinemia will be there. Because of the obstruction, the conjugated bilirubin, because of the obstruction and cholestasis, the conjugated bilirubin cannot reach the intestine, whereas they can seep and reach the blood and they will be reflected as direct hyperbilirubinemia. Children, post-hepatic or obstructive jaundice will be raised total bilirubin and much of them will be direct bilirubin. Since the bilirubin is not reaching the intestine, urobilinogen will be totally absent. And the enzymes like alkaline phosphatase and gamma glutamate transferase will be elevated. These are the enzymes which are present in the cell membrane of the liver as well as biliary canaliculi. Since biliary system is involved, these enzymes will be elevated in obstructive jaundice. And there will be passage of dark urine because of presence of biliary pigments and salts and pale stools because stercobilinogen is not there. Since urobilinogen is not reaching the intestine, no stercobilinogen, pale stools. And conjugated bilirubin can be present in the urine, which is resulting in dark urine. There are also other special causes of jaundice, and some of them are Gilbert syndrome, Crigler-Najjar, Dubin-Johnson, Rotas, neonatal jaundice, and due to drugs like probenecid and rifampin. And if you talk about this, in the Gilbert syndrome and Crigler-Najjar, the problem is in the conjugation because some of the enzymes involved in the conjugation is absent. UDP glucuronidase transferase deficiency. It can be mild and it can present as Gilbert, or it can be severe, as in case of Crigler-Najjar type 2, and it can result in increased mortality, early mortality. Dubin Johnson and Rotar is because of absence of transport protein. Okay, the MRP, multi-drug resistant protein, right? That is absent or there is defect. And it can result in Dubin-Johnson and Rota. And Dubin-Johnson is very severe form in this and it can result in blackening of the liver. Okay, black liver. And neonatal jaundice, here if you see, the neonatal liver is immature and is also, there is increased hemolysis because the fetal hemoglobin are lysed. There is increased bilirubin production and that cannot be handled by the immature liver, and this results in neonatal jaundice, and the treatment is going to be phototherapy. And in probenecid and rifampin, they compete with bilirubin for uptake by the liver, and therefore they can result in hyperbilirubinemia.